Welcome to tonight's webinar on HRD testing in ovarian cancer. It is great to have colleagues from across the country tuning in. I'll start by running through a few housekeeping points, provide some more context for this webinar, and briefly outline our guidelines project before introducing our wonderful speakers. Please know this webinar will be recorded and the recording will be shared with participants and be available on the Ovarian Cancer Australia website. We will also share the final tumour testing guidelines document in the coming weeks as well. There will be the opportunity to submit questions during tonight's presentation, as well as an opportunity to participate in some poll questions. The poll questions will appear on the right-hand side of the screen, and we will let you know when it is time for each one. I'd like to take this moment now to thank both AstraZeneca and GSK for their kind support of this webinar, the broader guidelines project, and their efforts to bring HRD testing and expanded PARP access to Australia. In Australia, HRD testing has been occurring in the research setting for some time, but hasn't been widely available or government subsidised. After repeated efforts, not only by OCA, but many others on the call tonight, and more broadly across the sector, in July 2023, the PBAC and MSAC committees recommended the funding of 2 HRD tests alongside expanded access to PARP inhibitors for this additional group. We eagerly await sign-off from the Health Minister to see these recommendations formalised. We know too that when somatic BRCA testing became standard of care in Australia, it took some time for the rates of eligible patients accessing somatic testing to increase. And so in light of that, we wanted to be prepared for HRD testing, which is what led to this project. Ovarian Cancer Australia convened an advisory group to consider what we're aiming for in regard to upfront tissue collection for newly diagnosed advanced high-grade serous ovarian cancer patients. We aim to answer questions such as who should have their tumour tissue tested, when should this testing occur, and what constitutes adequate tumour tissue collection. We considered what was available in the literature, what the experience had been overseas in jurisdictions where HRD testing has been more widely used, and the challenges and experiences our clinicians have experienced on the ground. All this culminated in the development of consensus guidelines for optimal tumour tissue collection in newly diagnosed advanced ovarian, fallopian tube, and primary peritoneal cancer patients. The guidelines will be launched in the coming weeks, and I want to take this opportunity to thank all those clinicians who generously lent their time and expertise to this project, including our speakers tonight. So without further ado, I would like to introduce them now. Professor Anna DeFazio will provide an overview of HRD testing before facilitating a case study discussion with our other panel members. Our wonderful panel tonight include members of the multidisciplinary team, including representation from gynae-oncology, medical oncology, pathology, and translational research. These members, alongside Professor DeFazio, include Associate Professor Lyndall Anderson, Dr. Michael Burling, and Dr. Yi-Chen Lee. So thank you, Anna. I'll hand over to you now.
Thank you, Bridget, for that introduction. So my task today is to give you a little bit of an overview of HRD, but before I'll start, I'll give an overview of why we're all here, and that is to think about epithelial ovarian cancer. So as most of you will know, epithelial ovarian cancer is most often quite advanced and widespread at diagnosis. And until recently, treatment for most patients has been largely the same. So surgery to remove as much tumour as possible with carboplatin paclitaxel chemotherapy, either given adjuvantly or neoadjuvantly, plus or minus bevacizumab, depending on clinical circumstances. Now, most women with ovarian cancer will initially respond quite well to this treatment, but the development of acquired resistance is quite common. And as you'll see from the graph on the lower right, the 5-year survival for ovarian cancer is quite low. We can see a bit of an uptick, which is very heartening, but still ovarian cancer survival, 5-year survival, remains under 50%. So one of the features that we've learned about in studying ovarian cancer over the last couple of decades is that while, as I've said, the treatment has remained largely the same, when we look at ovarian cancer, we can see that there are many very distinct subtypes. So just looking down the microscope, the pathologist can tell us that there are different histological features. So they're shown here. So the most common being high-grade serous ovarian cancer, endometrioid, clear cell, low-grade serous mucinous and carcinosarcoma being the most common. So what the circles are showing us, though, are the different mutations that occur in these different subtypes. Now, we won't go through all of the details that are shown here, but suffice it to say that what you can see immediately is that all of those circles are different colors. And what that's telling us is that each of these different subtypes have got different underlying mutations. So high-grade serous at the center there has got a black circle, and that black circle is P53. And so P53 occurs in nearly all high-grade serous. Whereas to the right, you can see low-grade serous don't have any P53 mutations. So those mutations are driven by the greeny color ones, so the RAS pathway mutation. So really quite distinct mutations that occur in the different subtypes. So we shouldn't be at all surprised that the different subtypes have different clinical outcomes and respond differently to different treatments. And it's really understanding these differences and understanding the different treatments that are needed given these different subtypes is where now that we're really starting to make some headway in terms of improving outcomes for patients with ovarian cancer. But tonight we're going to focus on high-grade serous. So high-grade serous, as I've mentioned, being the most common subtype. But for tonight, the main thing about high-grade serous is that it's really characterized by alterations in the homologous recombination DNA repair pathway. So alterations in this pathway are really quite common. So about 50% of patients with high-grade serous will have an alteration somewhere in this pathway. And this has been shown in a number of studies over the last decade or so. So looking here at the TCGA data from 2011. So in that study of high-grade serous, about 51% of cases were shown to have an alteration in the HR pathway. And a similar study, the International Cancer Genome Consortium study by Patcher et al., led by David Botel and Sean Grimman, showed a very similar result, that about 50% of patients with high-grade serous have an alteration in this pathway. The most common genes that are altered are our friends BRCA1 and BRCA2. The other thing to note, which will come up again in a little while, that these alterations can be inherited. In other words, they come through the germline, or they can be somatic and occur during tumor development. So what is HRD? So HRD is a mechanism by which cells repair double-strand DNA breaks. So the genes that are involved in this pathway detect these damage and repair this damage using what's a templated or highly accurate type of DNA repair. So the repair is done using a template so that it's very accurate. So if there's an alteration in this pathway, which I've shown in this figure here, the genome can become scrambled. So what you're seeing in the top plot is from a SNP array, and we'll see a few of these during this talk. And that line across the middle shows the DNA copy number changes in each of the chromosomes from chromosome 1 all the way through, lined up in order. And there's not very many changes in terms of increases and decreases across the genome in normal circumstances. But once one of these genes becomes altered, in this case showing BRCA1, the genome becomes scrambled. So we have very characteristic alterations that can occur all through the genome, and you get this scrambled effect with lots of gains and losses all across the genome, as you can see in that bottom panel. So of course we've taken advantage of this. Well, when I say we, say other people have taken advantage of this in developing PARP inhibitors. So again, this figure showing that when there's DNA damage, if there's HRD, we can have, when there's homologous recombination repair is active, that that break is repaired. If it's dysfunctional, the cell has to take another route, which is an alternate repair pathway, which is not as accurate. But if that is also blocked by the use of PARP inhibitors, it leads to an increasing rate of unrepaired breaks and ultimately cell death. And then that's, that has, of course, led to really the remarkable results that we've seen in clinical trials of PARP inhibitors such as olaparib here, showing the Kaplan-Meier for progression-free survival in ovarian cancer patients with a germline variant in BRCA1 or 2. And what you can see is that very remarkable increase in progression-free survival for patients on this treatment. But of course, that then begged the question, if we get such good results with BRCA1 and 2 germline, what about the other members of this pathway? What about response to PARP inhibitors beyond germline BRCA1 or 2 alterations? We know that there are many genes in this pathway, and individually, the alterations in these pathways are not terribly common, but cumulatively, they make up about 13% of high-grade serous. And there are other alterations, such as hypermethylation of BRCA1 and RAD51C. So the question really became, will PARP inhibitors also be effective in these other tumours that have become defective in HRD through other mechanisms apart from BRCA1 and 2 germline mutations? And what we've pulled out here are Kaplan-Meiers from 2 of those clinical trials, the top one being from the NOVA trial. And you can see in patients that are BRCA germline wild type, but have HRD through one of those other mechanisms, you can see that improved survival with niraparib. And similarly in the bottom panel in Palo 1, again, BRCA wild type, but with HRD through a different through an alternative mechanism, also an increase in survival with olaparib now in combination with bevacizumab. So really, great results from clinical trials showing that it's really not only germline BRCA1 or 2 patients that may benefit from these treatments, but really a broader range of, or patients with a broader range of alterations in this pathway. So the question then becomes, how do we test for HRD? So we can test for the causes of HRD, in other words, the BRCA germline or somatic mutations that I've mentioned, or mutations in those other members of the pathway, remembering that these are all very large genes, and it's we need a lot of coverage to be able to look for mutations in all of the regions of all of these genes. And then there's promoter methylation, etc. So we can look for the causes of HRD, and that is certainly something that's being done for some time. The other thing that we can do in addition to that is test for the consequences of HRD. In other words, for this genomic instability or the mutation signatures that occur in the mutations that result from HRD, or it can be a measure of the genomic damage that occurs as a result of HRD, sometimes called the genomic scar. So these are different ways that one can look for HRD, either the causes or the consequences, or a combination of both. So there are now a number of assays that have been developed to look for this genomic scar. So the causes, the mutations can be looked for with panel mutation testing or other forms of mutation testing, but a number of new assays have been developed looking for those consequences or genomic scar. And I've only put a couple of them up here, really more to give an example of the sorts of assays that are now or have been available and are now becoming increasingly available. So many of you will be familiar with My Choice from Myriad Genetics. So it uses a diagnostic technique of the SNP array, similar to what I've shown you in those examples. And that's a genomic instability score combining 3 features that I'll explain a little bit more in a little while. There's also Foundation Medicine. They have an assay, their BRCA loss of heterozygosity assay, again using these high-density SNP arrays. And more recently, an assay that's become available in Australia is the Sophia Genetics assay. So this uses a different technique. So this uses low-pass whole genome sequencing. And so that uses a deep learning algorithm that looks at that shallow whole genome sequencing to measure this genomic scarring. And what I've not added here, but is also done in Sophia Genetics, is somatic and germline testing of about 28 different HRR genes. So really, this is a table just to give a little bit of an example of the different types of HRD assays, and to make the point that there are different assays, they use different techniques, slightly different cutoff points, slightly different definitions, and there seem to be more and more of them coming onto the market. The other point I'd really want to make is around the tumor type. So Bridget alluded to this. So really to focus on the different tissues or biospecimens that can be used for detecting HRD, whether it's the cause or the consequence. So the first, and the one that we've been talking about mainly in terms of HRD, is looking at the tumor tissue. Now, the tumor tissue will give both somatic or germline mutation testing. Sorry, both somatic or germline mutations. So that is an advantage because you can get both. But it's also a limitation because it doesn't distinguish between the two. So if there's a mutation found in the tumor, of course, one then needs to do germline testing to see that whether it is germline or somatic. Now, tumor tissue testing, as I said, has got that advantage of being able to look at both somatic and germline at the same time. But we do need to understand one of the limitations, and we'll talk a lot about this later on in the case study, in that the samples can be quite heterogeneous. So they can have malignant cells in there, but they can also have normal cells. So those normal cells can be stromal cells, or they may be lymphocytes. So the proportion of tumor cells to normal cells can really affect some of these assays. And many of the assays have got a cutoff in terms of the percent tumor that's allowable or in terms of going forward with the assay. And that's generally around 30%. Having said that, it can be quite challenging to accurately determine that tumor percentage, particularly if there are infiltrating lymphocytes. It can be quite deceiving in terms of the amount of tumor tissue you might have in a sample. And then, of course, there's the issue of the effect that neoadjuvant chemotherapy can have on the DNA and on the cells, areas of necrosis, etc., that can really cause havoc with the DNA and then impact on the ability to be able to undertake some of these assays. The other limitation is that some of the panel mutation testing can miss large deletions in BRCA1 or 2. So there are certain things that can be missed in the tumor tissue. So certainly advantages and disadvantages of looking of tumor tissue, but just limitations that we need to be aware of. What many of you would be used to looking at is germline DNA, so either blood or saliva. And so this is really looking at familial implications and in terms of BRCA1 and 2, but it does not identify the somatic mutations. In other words, it'll pick up the 18% or so of high-grade serous where the mutation is in the germline, but will miss the cases where the HRD is somatic or caused by other alterations. So very important to understand that difference between somatic and or tumor testing and germline testing, and what you can tell doing the two. So just to put some of what I've just told you into context, I'm just going to show some results from a study that we've undertaken over the last few years in New South Wales, where we have recruited patients from across the state for a whole raft of molecular testing. And one of the tests that we introduced back in 2016, understanding that PARP inhibitors were definitely well and truly on the horizon at that time, and the HRD testing was going to be very important in the near future. We introduced both mutation testing, as well as HRD testing, really to prepare us all for what's happening now, which is that moving of the HRD testing into more mainstream clinical testing. So in this study, we recruited patients from across the state, either at diagnosis or at relapse. They had the standard primary treatment, as I've said, a whole raft of molecular testing. And if the patients were no longer responding to standard treatment, we were then armed with that information to triage the patients into different clinical trials. And a big proportion of that, particularly for Innovate 1, was to triage patients with HRD and BRCA or other mutations in that pathway into clinical trials of PARP inhibitors. So there have been over 800 patients recruited to this study. So I'll just take you now through some of the results, certainly not all of the results, but only the results really that are related to what we're talking about tonight. So looking here at the results for testing for the BRCA variants, both germline and somatic. So what we found is that BRCA pathogenic variants were detected in about 26% of the first 334 high-grade serous ovarian cancer patients. This turned out to be about 18% of germline and 7.5% of somatic. So nearly almost exactly what we would have expected given the previous results from other studies. And what we found was one of the limitations that I pointed out was that using the panel mutation testing that we undertook, there were a couple of cases, 3 cases that we didn't identify because they had those large genomic rearrangements. So pointing out that limitation of panel testing. So as I said, we also introduced HRD testing, and the assay that we developed was based on a SNP array, so similar to the Myriad genetics test, that was a combination of 3 features. So telomeric allelic imbalances, large-scale transitions, and loss of heterozygosity. So the 3 measures that Myriad genetics also look for. And in our score, this was computed using we computed the arithmetic mean of those 3 genomic lesions. And just to go back to showing you the SNP arrays that I've shown previously, the top one that by now you'll see is the normal, so no changes across the genome. The panel in the middle is an example of an HR proficient high-grade serous. So as you can see, there are some changes across the genome, but they're not that scrambled look that you get from the bottom panel here, which is that HR deficient. So that real alterations that you see all across the genome that gives you that what's called genomic scar. So putting those the results into this panel to show the results for where we know the mutation, what the mutations are. So what you can see here on the you can see on the axis that we have the score that's given, that arithmetic mean, and the cutoff, which is at about 17.7 in this particular assay. And what you can see in that very first panel, or the very first set of samples, are that samples with a germline BRCA1 mutation are nearly all above the line, in other words, HR deficient. The next ones along are the somatic BRCA1, again above the line, BRCA2 germline mutations, and somatic BRCA2 mutations. So all of the ones that you would expect, all sitting above the line. So, and then we go on to, we can see here the cases that have some of those other alterations. The first thing to point out is the blue diamonds, which are the BRCA1 methylation. So really by far the most common other alteration. And what you can see here is they all sit above the line, HR deficient. And the same goes for all of those other less common mutations that you can see in the different colors in that bar. Given that there are still some cases, for instance, there's one RAD51C mutation that falls below the line. So in this assay, HR intact. And then at the end here, we have our remaining cases. So a couple of points to make here is that there are still a few cases above the line that are HR deficient, for which we don't yet have a cause. So we don't know what the cause is. And we have a PhD student, Nick Nevins, who is doing a lot of work around trying to understand all of the underlying features that lead to these mutations. The other thing I'd like to point out here are the number of cases around that cutoff. And so there are, we have to be very mindful that this is not a black and white assay. It's a continuous variable, and there'll always be those cases around that cutoff that may flip from one to the other. Just even same sample from the same samples from the same patient in different regions of the tumor, for instance, can just flip backwards and forwards. So there's that slight grey area. We really need more research to understand that more fully. So in summary then, for Innovate, very similar results to what I've shown you. About 50% of cases with high-grade serous have got an alteration somewhere in that pathway. So in summary, where HRD score was able to identify all the BRCA altered and non-altered HR deficient cases. There are some limitations. So we've got threshold limitations, that definition of the threshold. Point out the scores from different HRD assays are not always concordant. Sometimes they can be a little bit different. Remember the SCAR assay is retrospective, so reversions or loss of methylation can reverse HRD, but they are not detected. And there are more functional assays on the horizon that may be needed for that type of analysis. So in conclusion, the identification of BRCA variants associated with high-grade serous patients is now standard and allows for PARP maintenance treatment. In addition to BRCA1 and 2 mutation, BRCA methylation is the most common cause for HR deficiency, followed by mutations in their less common subtypes. That measurement of the SCAR is not only effective in identifying cases of BRCA genetic variants, but also those with the additional HR deficiency by other mechanisms. And really, by identifying this group will increase the utility of PARP inhibitors in clinical practice. So that just leads me to thank all of the Innovate investigators for allowing me to share this data with you, to point out Christina Mapagu and Sway Tanzu, who were really the powerhouses behind the HRD assay. Nick, who I've mentioned, who's doing a lot more work around understanding the issues around HRD testing. Dashni, who's done the mutation testing, and Alex Dobrovic and his team, who really did a great job at looking at methylation. And then I'd like to point out our panel members. So Michael Burling, Chen Li, and Lyndall Anderson, who are also fantastic Innovate collaborators and who are going to join us now for a panel discussion. So Chen, I might hand over to you for the case presentation.
Thank you, Anna. What a lovely summary in a very succinct fashion, consolidating years of work. So let's change the tune a bit, and now we come into the clinical practice. So I do have the permission of my patient to present this case, and this is meant to be interactive. So please do look into the right-hand side of your panel, where when there's the time for polling, I will let you know so that you can actually contribute and engage with us in terms of some of the decision-making process. So I have a 59-year-old, otherwise fit and well mother of two, who over Christmas last year has developed some symptoms of abdominal bloating and discomfort. So she initially didn't really think much about it, but it seems like when she was prompted with more questions, there's actually not much of other symptoms to be bothered with. However, these symptoms continue to persist, and she seeks medical attention with her GP. The GP asked whether she has any family history, and it was noted that there was no any family members with cancer in her family. And certainly, with the persistence of abdominal symptoms, and pelvic ultrasound was ordered. And this unfortunately revealed a right ovarian mass as well as the presence of ascites. So I might kind of give the floor to Mike. This kind of presentation and women come to your practice, can you please walk us through how you will process the workup of the presentation?
So I'm unmuting just, and yeah, this is a very typical presentation of ovarian cancer. We know that these non-specific symptoms, and these women usually will have, this woman didn't have any bowel symptoms, but one of the other common symptoms is bowel issues. So these women get investigated for bowel issues and a workup for colonoscopies, gastroscopies, and things. But in this woman's case, so this is not this is a very typical way these patients present to the GPs. GPs generally either order very simple investigations, so pelvic ultrasound and some blood tests depending on the abnormal results, and then they usually will refer on to a general gynecologist or a medical oncologist if there is a CT scan or an ultrasound saying, query cancer. The other route goes to a medical oncologist for a workup, and then the tumor markers that usually accompany these scans. There's a CA125, a CEA is the other main one, or CA1 19.9, but the CA125 is most certainly the one we will be looking at. Obviously, if these are abnormal, as in this lady, people will go on to doing other investigations, including a CT scan and a PET CT scan. And then usually we as medical oncologists or surgical oncology, gynae oncologists will organize the investigations to prove cancer. As Professor Brand always says, tissue's the issue. So either we try and get cytology, as this patient did have, or a biopsy, which is usually preferred. But I'll leave you to bring that across.
And suddenly she has gone through a series of tests, and unfortunately what has come to light is that her CT scan confirmed the presence of peritoneal nodules as well as the presence of ascites. And at this stage she became more symptomatic about her abdominal bloating, so hence the ascites fluid was sampled and drained. So she also have a PET scan, and this, aside from the abdominal disease, unfortunately did show some abnormality in the uptake of lymph nodes at the base of her neck, as well as one small pulmonary nodule. She never really had scans in the past, mainly because she has always been fit and well, so it's hard to actually attribute the pulmonary nodule as malignant, but it is actually quite a small nodule, less than 1 centimeter in size. Her blood test shows CA125 of 487 kilounits per liter. So just to give a normal range of a CA125 is usually about 35 kilounits per liter, so that's very abnormal. Her CEA and CA99 was normal. So let's move to a gynae-onc MDT. She was presented her case, and perhaps she was thought not suitable for upfront surgery. Is that actually kind of quite common in our practice as well, Mike?
Yeah, and obviously all these patients come through our MDT, which we all sit through, and the PET CT scan, a suggestion of disease outside the abdominal cavity most certainly will up stage her to a stage 4B. We as we all know, that there's been 4 randomized controlled trials on upfront surgery versus interval debulking surgery that showed that there was less morbidity in terms of interval cytoreductive surgery following neoadjuvant chemotherapy, but no detriment to survival. So, this is not an unusual decision-making from a gynae-onc MDT. I think the pulmonary nodule is probably just an incidentaloma, but something that we would keep an eye on, as these patients will have to have repeated scans. I guess one of the really common ones, and I think Anna and I sit through the Westmead Gynae Oncology, is the decision to get more tissue, especially when we have a significant number of our trials requiring pre-chemotherapy tissue sampling, and that's always one of the things that we talk about, is do we go for a core biopsy or a diagnostic laparoscopy to get a biopsy here?
That's excellent. So this is very timely. So this will be our first testing run for our polling question. And if you can go to the right-hand side of the screen, you should be able to kind of click on your decision in terms of what would you do as the next step. In this setting, we have ascites fluid confirming adenocarcinoma of gynae origin. Would you proceed with neoadjuvant chemotherapy? Or B, would you obtain tissue biopsy before proceeding with neoadjuvant chemotherapy? Let's give some moment for the polling to roll. Lovely. I hope you can appreciate the answers on the right side as well. So what we can see is that 12% say go straight to neoadjuvant chemotherapy and 88% proceeds with option B, obtain tissue biopsy before neoadjuvant chemo. And I'm glad that majority of you actually think this way. As Mike has already mentioned, it is quite important to actually confirm the diagnosis, but on top of it, be prepared, given that the ultimate trajectory of this disease is that we will need more understanding, and certainly to facilitate understanding and personalized medicine, we will need to understand what is going on within the microenvironment of the tumor tissue. So this lady actually proceeded to a diagnostic laparoscopy, and a peritoneal nodule was biopsied and sampled. Lindo, can you walk us through the findings?
The features, absolutely. Thank you. So we've got two images up on this screen. Both of these are hematoxylin and eosin stained sections. The one on the left is slightly lower power, and the one on the right slightly higher power. On the left, you can see we've got diffuse effacement of what would be otherwise normal tissue by this very irregular looking tumour. There's a little bit of desmoplastic stroma along the top, which looks a bit spindled, and the rest is a pretty wild looking tumour, mostly solid. The image on the right shows little round purple, like concrete pebbles. These are pseudomonas calcifications, and this gives us a clue that it might be serous. And that solid morphology with severe nuclear pleomorphism tells us that it's almost certainly going to be high-grade serous. But we would proceed to immunohistochemical staining just to lock in features such as a P53 mutation, a WT1 for site of origin. The image on the screen at the minute is a P53 immunostain, and that's a nuclear stain. So we're looking for strong positive nuclear staining of tumour cells, and that would be the most commonly mutated pattern. There is a much less common sort of null phenotype where the tumour is completely blue, and a very rare cytoplasmic stain, but this would otherwise be classical high-grade serous adenocarcinoma with a P53 mutant stain. We would expect the WT1 to be positive, and that would put us very much towards primary peritoneal, fallopian tube, or ovarian origin, for example. Thanks, Jen.
Thank you, Lindo. I might throw in another question for you.
Sure.
As we actually have this question about ascites fluid cytology diagnosis
Yes.
versus a peritoneal biopsy.
Yes.
How do you tell them apart? And can you say, is cytology enough?
So what I think you're asking, because actually the cells are the same, so we can't tell them apart, it's the same process. Cytology has advantages and disadvantages. The advantage of a really good acidic fluid sample is that you can produce a beautifully cell-rich cell block, and we can actually use them now for somatic BRCA testing, but unfortunately the technology is not widely available. It's only just starting to emerge for the HRD testing on cytology. So if we've only got cytology, no matter how beautiful the cell block looks, and we create those by gently centrifuging the samples to quite a pure sample, we can't use it yet for HRD. Morphologically, they'll still look the same, so it's the same tumour in the same patient, but very different what we can do with them. And moving forwards, it's nice to have that archival material, that formalin-fixed paraffin embedded block, because there's new testing and new platforms being made available all the time. So more is more for tumour in our blocks.
Lovely. So the patient has come to me as a medical oncologist, and we discussed the options about chemotherapy and certainly the implications of such diagnosis. So now I would like to activate polling question number 2 to the audience. So when would you perform genetic testing? So there's option A, B, and C. So option A, we will do the germline testing, which requires a blood sample right now, and wait for interval debulking surgery to proceed with somatic and HRD testing. Option B, we will go for both germline as well as somatic and HRD testing using the laparoscopy sample from the tumor tissue. And option C, somatic and HRD testing from the laparoscopy sample right now, and then we'll defer germline testing for later as there's really no family history of cancer. So option A, B, and C. Let the poll begins.
Chen, can I ask you a question?
Mhm.
Would it be incorrect to give neoadjuvant chemotherapy in that first setting in some patients? Like we do have the, very unwell stage 4 patient that can't undergo a laparoscopy, or that we know that a lot of our patients come from rural places that don't have facilities for biopsies. What's your thoughts there?
Yeah, it is true. At the end of the day, it's the patient in front of us and their current situation and symptoms that matters. Um, Unfortunately, sometimes when the symptoms is at heightened state, it is important to facilitate chemotherapy ASAP. And with that in mind, obviously efforts can be made to try to alleviate symptoms and we may be able to do an attempt or biopsy using radiologic guidance. But certainly if there's the immediate rush, we will move on to neoadjuvant chemotherapy with that understanding that we will find opportunity later down the track. And certainly, even at times of disease recurrence, every opportunity, every time point where clinical decision is required, we would actually assess and see if we need more tissue diagnosis to confirm the diagnosis, if not reevaluate. So now we have our polling answers. So majority actually choose option B. 82% will go for both germline testing and somatic HRD testing straight away. And we have a slight division with 10% will choose option 1, germline testing first. And then 10% will say we'll go for somatic testing first right now, while germline can wait for a bit later. To be honest, at the end of the day, there's no absolute correct or incorrect answers. It all comes down to the timeline and the timing of testing. At the end of the day, every facility is a bit different, and whether the timeliness of the sample and the timeliness of the results will actually make a difference. And usually in this setting, germline testing has implications to the patient as well as their family. And certainly the results of somatic testing and HRD testing, as we learned from Professor Anna Di Fascio, that it has implications to our maintenance treatment decision. So usually around this time, we have about 3 months before we have to make the ultimate decision about maintenance treatment. And certainly, if that's the case, we should be able to facilitate the discussion. I certainly will not do all the consultation about the diagnosis of cancer, the discussion of chemotherapy, as well as the implications of genetic testing all at once within a less than 40-minute kind of clinical consultation. So it all takes time to digest. And certainly I would actually move it along as the patient being able to kind of digest and process the news a little bit better. Okay. Now, why should everyone be offered testing? We know that all patients, as long as they have non-mucinous ovarian cancer, should be offered BRCA testing. And it is from all the series of data and literature and certainly understanding of ovarian cancer that we now know that aside from the 15 to 20% of ovarian cancer patients that carry BRCA mutation, Their mutation carriage status is not restricted to younger patients, and certainly 40% of the women with BRCA mutation does not actually have a family history. So that's why the current guidelines actually advocate that all patients, no matter their age, should be tested for BRCA. Now, so my patient has consented to chemotherapy and proceeded to carboplatin paclitaxel with bevacizumab. She tolerated chemotherapy well, and as you can see on the right side of the curve, the CA-125 has a swift response like Anna predicted. Within first cycle, CA-125 has come down to 100, and suddenly by cycle 3, the CA-125 marker has normalized, indicating a good response. Symptom-wise, her abdomen has softened. She did not require another ascites drainage. Her ascites fluid seems to just resolved. So now the CT scan was performed and it overall confirmed the improvement of disease burden. And I would like to invite Mike back to the picture and say his decision-making process for interval debulking surgery.
Yeah, surgery is certainly still the cornerstone of managing ovarian cancer, and one of the things that we can have the ultimate influence on survival outcome. This decision is we usually take looking at a few factors. So looking at the patient factors, so how well is the patient going through their treatment, what their ECOG status, their nutritional status is, and symptomatically how they've gone through their treatment. And this patient's improved significantly. The second is radiological changes. So we review their images from pre and post 3 cycles on neoadjuvant chemotherapy. The most guidelines, you can use PET CT scans or straightforward CT scans. You just need to see that there is stable or a resolution of disease. And then the other main factors are what your facility can offer in terms of the ability to perform, the extensive surgery, because sometimes in certain facilities we can't do as extensive as other facilities, and that is an important thing to take into account. And the other thing I didn't mention before, but was her biochemical response. So CA-125 decreased very significantly, and that shows that she's had a very amazing response. So if there was equipoise that you didn't know if this patient was going to be suitable for surgery or not, we would do a diagnostic laparoscopy prior to the proceeding with surgery. Laparoscopy, as we pointed out before, as somebody has pointed out, there's the risk of port site metastases that actually has never shown that impacted the survival outcomes in these patients. And doing repeated taps or biopsies still have the same sort of risk factors as a laparoscopy. But a laparoscopy, to me as a surgeon, has a few benefits. One, we are allowed to determine the extent of the disease, what we need to plan for when we operate, because this is a big operation. And I always say to my fellows and the patient as well, is that this is our best chance to influence survival outcome. We go for optimal cytoreduction. We want to resect every bit of cancer we can see within reason, but you want to go for gold. So I think this patient had a laparoscopy prior to the interval debulking surgery, and that allowed to plan for a colorectal surgeon to be present at the time of the surgery, because you needed I think she needed 2 bowel resections to get complete cytoreduction, and she was most certainly suitable for surgery.
I might also kind of draw Lyndall's attention to this. So she did actually proceed to interval debulking surgery, and everything was uneventful. And a complete specimen was brought to your attention. And can you walk us through
Yeah, definitely. So the image on the left, you can see the specimen has been bivalved and there's colorectal tissue down the center and the two halves of the uterus. And it's actually extremely difficult to see where, if any, tumor is present. So I guess if we were going to be waiting for the post-chemotherapy specimen to do LA testing on, we'd be in real trouble here. Well, it's great for the patient, disaster for the pathology team. In the image on the right, you can probably see the fundus of the uterus centrally, 2 fallopian tubes and 2 ovaries. In the ovary to the left of your image, there's just like a little yellow, almost corn kernel stuck on the surface. And those are the little areas that are abnormal that we're preferentially going to target for sampling, because they look a little puckered and scarred and indurated to me. On the next image, if you have a look at the microscopic appearance, that yellow color is a combination of cholesterol clefts and crystals and foamy macrophages, which you can see on the right. And it actually contains 0 viable tumor that's useful for testing. On the next imaging, you can see where we've tried to look around and try and find something viable for immunohistochemistry. If we could advance to that image, I can speak to that. Lovely, thank you. So you can see a tiny little bit of viable tumor surrounded by desmoplastic stroma. The quality of that DNA is terribly damaged by the chemotherapy, and it often fails somatic testing at this point. So this patient had a wonderful response. She's had a chemotherapy response score, or CRS score, of 3, whereby 3 out of 3 is a wonderful response. We barely see any viable tumor left at all, but it is a complete disaster for molecular testing at that point. But great response for the patient. Thank you.
Lovely. And then we might also take the opportunity to talk about her genomic testing results. Anna, can you take it on?
Yes, so fortunately we had some of the sample from that original biopsy, so we weren't relying on the tissue that Lyndall has just shown us, which would be very difficult to get any results from. So what you can see from the Innovate results is this patient has a P53 mutation. I'd mentioned earlier that this is very typical of high-grade serous. We see that in nearly all cases, so that's tick. And this particular patient on our assay came up as HR deficient, so HRD score of 19.67. So really very fortunate that we had that earlier sample that we could test to show that she was HR deficient.
So after the surgery, she completed chemotherapy, and we gave a total up to 6 cycles of carboplatin paclitaxel with bevacizumab. And then, given the HRD results, we have actually commenced her on maintenance olaparib with bevacizumab. And as you can see, these are the kind of the longitudinal trajectory of a CA125. It came down and remained quite low along the track. She tolerated treatment very well, and her treatment is currently still ongoing. So I hope I can use the advantage of this case to demonstrate how important it is to have adequate tissue sampling, and particularly every opportunity is gold, and particular if it's of particular importance if it's actually pre-treatment, so that we have the best chance to kind of characterize the disease. We also talk about the importance of genetic testing, and not everyone has to have family history of ovarian cancer, but everyone should be tested as long as they have a non-mucinous ovarian cancer diagnosis. We also talk about the importance of HRD, and certainly current era where we have implications to maintenance treatment that can impact on survival outcome. We all know that 1 in 5 patients will carry BRCA mutation, whether germline or somatic. And certainly 1 in 2 patients has HRD positive disease. So it actually translates to overall 1 in 2 patients with ovarian cancer can respond to a PARP inhibitor. So I think this is where we open up for Q&A session. I will give you the floor, Anna.
Okay, so we have a couple of questions in the chat here. So the first is around CT-guided biopsy. Can that be done on, say, an omental cake rather than a laparoscopic surgery?
Absolutely, there's no doubt about that. I think as long as you get at least 3 good core biopsies, I think at least 16 gauge biopsies. I think the more tissue you give Lyndall, the happier she will be. More DNA, that we can run for extra testing. But yeah, absolutely, as equivalent to laparoscopy. But you just got to remember that occasionally, even with CD guided biopsies, they can miss the disease. But if you have a lot of disease, you're unlikely to miss. So yeah, it's as equivalent to laparoscopic surgery.
And if I can just reinforce what Mike said, just because you've given 5 really good looking biopsies doesn't mean that translates to tumor down the microscope. You can have fat necrosis, which looks and feels like a tumor at times and will have abnormal coloration of the tissue. You can just get the desmoplastic stroma or calcifications. So really, you do need microscopic confirmation that you've got tumor as well. And it is a little bit operator dependent, depending on the centre that's taking the biopsies. So do wait for confirmation before you start the chemo where possible. But sometimes it's just not safe to proceed with the laparoscopic biopsies.
And while we are on the topic of tissues, there's actually opportunity to actually emphasize that every tissue is important. It's every chances that we can get a tissue sampling is also valuable. So obviously, if we have a priority kind of layer coming through, laparoscopy resection tissue is important and perhaps more adequate. More tissue is best. And then if we bring down the hierarchy, it will be then perhaps a radiological guided tissue diagnosis biopsy, and then the cytology specimens. I understand that Peter McCallum would actually accept cytology cell block, like Linda, what you mentioned before.
Yeah, that's
but suddenly
wonderful. That's relatively new, I think.
But certainly quality and more tissue access is better. So if you have a choice between a diagnostic block versus cytology, I would send the diagnostic block.
Chen, you have one more question.
Yes, go ahead, Lyndall.
Anna, I think you saw it just pop up as well. We've got time for one more.
So will the new MBS funding for HRD only allow 1 test per patient? Will you have to make sure you get the best sample tested to give it the best shot for subsidized testing?
I must admit, it is hard to predict what the MBS funding will be allowed for, but obviously we want if we only have 1 chance, we will go with the best possible block. And usually this is the time where I give Linda a call and say, can you give me the best tissue? And which one would that be to send it away? So Linda will give us a little preliminary prediction, and then we'll send the best tissue away. But yeah, I have no clue as to whether there's a once in a lifetime kind of opportunity here for MBS funding.
And would anyone like to comment on the Compassionate Access Program before we wrap up?
Sure. So at the moment, there is a compassionate access program provided by AstraZeneca, where if a patient has BRCA wild type but HRD positive disease, they are then allowed to proceed with compassionate access of olaparib and bevacizumab in the maintenance setting. And this certainly, hopefully, will be different down the track where it may be approved by our Medicare and PBS, but we have to kind of work on it ongoingly and certainly watch the space.
Thank you. Well, thank you, everyone, for a really great session. I might now hand over to Bridget.
Thank you, Anna, and thank you everyone so much for joining. I hope you found it valuable. I definitely have. And I just wanted to say a big thank you to our speakers. They have generously given up their time, not only tonight, but also in the days and weeks leading up to today to prepare. So very big thank you. We've got some details on the screen, so please don't hesitate to reach out if you have any further questions about this evening's session or the guidelines project. And as many of you may be aware, Ovarian Cancer Australia does offer a wide range of free tailored support services to those impacted by ovarian cancer. So please also encourage all those that you care for to reach out if we can be of any assistance. Many thanks again and good night.